Morning, everyone. Just waiting for a few more folks to join and we'll get started shortly. And Martin, just confirm you guys are able to share, okay?
Yes, I'll go ahead and pull up the presentation now.
Great. I think we probably are at a size where we can get started. So welcome everyone to the December Advisory Council meeting, and looking forward to the conversation today. We had a provider meeting earlier this month, and we'll be discussing with some updates, some of that information shared there. And we're looking forward to the conversation. Again, always really appreciate everyone's input here. As a reminder, this is being streamed live on YouTube and being recorded there. So for those who would like to access this later or need to leave early, this will be up on the CTDSS YouTube website. I don't believe there's anyone else likely to want to kick us off today. I'll be passing over to Optimus, who will be walking through our slides and our conversation. And as always, we also have our Faulkner Consulting Group team, who's also here on the call with us. The commissioner will not be joining us today, but Guy, is there anything else you'd like to say at the top, just since you joined?
Nope, I'm ready. Let's jump in.
Sounds good. All right, Martin, I'll pass it over to you guys.
Would someone from the Faulkner team like to talk through the timeline before we roll into the presentation?
Yeah, absolutely. This is a slide that's probably very familiar to this group by this point, just kind of showing the different design elements that we've discussed today. For this month, we're focusing again on the different aspects of the payment methodology, financial risk, and social risk adjustment, as well as billing and claims. In January, we'll talk about how quality is linked to payment, as well as bring back some outstanding policy questions. And then in February, we're hoping to bring back the full bundle design and just kind of go through that overview. So with that, I'll pass it back to you, Martin.
Thanks, Tiffany. All right. The agenda for today includes payment and price structure, provider-specific target price, baseline performance, social risk adjustment, the prospective payment trigger, and then we have a time for questions. So to give you an idea of how this all fits together, the target price will include all three components: the physician group prenatal and postpartum costs, the physician delivery costs, and other provider maternity related costs. That under the target price, we'll be discussing the baseline performance and risk adjustment. On the other hand, the prospective payment looks specifically at the physician group prenatal and postpartum costs, and that is the attributed physician group for the pregnancy and delivery. And under prospective payment, we'll be looking at the trigger codes and trigger timing. For provider-specific target prices, the target prices include overall costs of the pregnancy and delivery for all providers. Provider-specific targets reflect a blend of statewide and provider-specific data. Inpatient costs will be adjusted based on hospital-based prices to mitigate cost differences between hospitals. We don't want providers responsible for just the difference in price between hospitals, depending on which hospital the patient goes to. The Prices for specific services may be adjusted for pricing differences between providers, just in case there are some historically high or low reimbursements that we'd like to smooth out. And for discussion, we have, is an initial 50-50 blend of statewide and provider-specific data reasonable to establish target prices? Are there any other costs that should be adjusted for beyond inpatient costs? So I'll pause there for any comments.
Martin, way back, I had thought that there was consideration given to a 75-25 blend provider or statewide provider. So depending on the order, 75 provider, 25% statewide. And so this is consistent with what's been said, certainly over the last few months. And the question is, do you have any concerns about whether this is too aggressive a reset of the price benchmark or a setting of the price benchmark, and what it might mean for the beneficiaries and the care of these of the patients who are high outliers, who are needing to save money quickly in order not to lose under the new model?
Yeah, that's a good question. We haven't gotten the data to the point where we can say what impact this would have. But to your point, if that ends up being a substantial, some less heavy blend on the statewide would potentially provide those affected providers with some relief.
And the only thing I'll add, Mark, you framed it as concern for members who have higher costs. And I know you know this, I'm saying this more for the benefit of others. So we're planning to do comprehensive clinical risk adjustment. So I'm more concerned not about particular members, but I'm concerned, or I think that the members, for example, who have chronic conditions and therefore have more expensive pregnancies, providers will not have any disincentive or incentive to take them. We're hoping to really level the playing field across the factors, at least, that we can include within our risk adjustment system. So I just want to make sure, I know you know that, Mark, but I want to make sure others understand that as well.
Thanks, Guy. I think that's an important clarification for everybody. I was more thinking about provider behaviors such as excessive C-sections and getting down to a C-section rate that is going to get you closer to under the benchmark and that kind of thing. I don't know what else there could be that would be ordering an excess of tests or whatnot. I'm too much of an amateur when it comes to obstetrics care to know. So, but to the extent that there are provider behaviors, irrespective of the risk of the clinical population, that don't get adjusted out, I just pose that as a question. I don't know that 50-50 is too aggressive, but I know that this kind of initiative is really a long game objective. You know, it's a marathon, not a sprint. If you go from 75 to 50 to 25 to, you know, to no provider history adjustment, it could be a softer approach that's at least worth considering.
Thanks for that comment. Any other thoughts or comments before we move on? All right. Then to continue looking at the provider-specific target prices. For year one, target prices will be adjusted to add amounts for funding, breastfeeding support, and doulas. To ensure reasonable trends in program stability, target prices may be adjusted for the AAE, which are actionable adverse event costs, C-section rate, and other factors. Right now, those aren't planned for year one, but may be implemented for future years. Any other comments on this slide before we move on? All right. Then taking a look at baseline performance. The historical claims form the basis for baseline performance. The first two columns of the following table represent current claims for the delivering physician group, separated by physician services and then laboratory, radiology, and other. The target price includes all the columns. So the first two columns here would be the physician group responsibility, and the prospective payment would include the non-delivery portion of these two columns. So not the entirety of this, but a portion of this will go into the prospective payment. And just to keep in mind that these are all draft numbers, they could potentially change by a bit before they are finalized. Yes, Karen, you have your hand up.
And just the other providers, what does that include?
So that would be, here we have the delivering physician group, laboratory, radiology, and other. So that would be, for example, non-delivery, the non-delivering physician group. So some other provider providing laboratory, radiology, or other services.
Got it. Thank you.
All right, Mark. Mark, you're still muted.
Thank you. So just to be clear, the bottom bullet says the prospective payment will include the practice-specific non-delivery portion of the first two columns. So that means that even though you reference delivering physician groups, the actual delivery is a separate cost that maybe is folded into the facility costs and hospital inpatient or other providers.
This does include the delivery portion that it goes to the delivering physician group. The distinction here that makes it difficult that we're still working through is that there are global codes under this that we have to separate out by the prenatal and postpartum and delivery portions in order to build the prospective payment.
So the delivery portion will not be part of the prospective payment.
Correct. And
So
that's what we have to separate out to not include in the prospective payment.
Understood. That was a question of our members because they often use their own delivering physicians. So anyway, I know it's in the plain language here, but I wanted to just walk through and make sure I understood it correctly.
Sure.
And Paula Greenberg here. And can you confirm that 2155 is the blended delivering? So that's that weight of 50-50 C-section?
This is all statewide. Or sorry, this includes the historical blend of vaginal and C-section, which is about, if I remember correctly, about 2/3 vaginal delivery.
Mm-hmm. Okay.
So yeah, so Paul, there's no adjustment at this time. This is just historical data as of now.
So,
Martin.
but it's a blend, right? That proposed number or target number is a blend of those deliveries. So you're saying it's 30% C-section and 60%, let's just say, normal vag, that's that fee?
Roughly, yes.
Okay, that's what I wanted to understand. Okay.
And just to be, and just to say out loud, the plan, going back to the prior slide, in year one is to have a blended provider specific rate with a statewide average rate, which is somewhat responsive, but just as a reminder, this is historical data. We will be looking to set rates based off of like the historical provider specific utilization, as well as that statewide average, which this number would be more respective of. Again, we're still waiting to pull out the delivery costs from that column. Martin, please modify anything there, but hopefully just wanted to clarify
that. Claudia, you have your hand up.
Yeah, thanks. I have two questions. The first is I just want to confirm that because this is historical data, the total on the 10,383 would not include any of the additional services that you're adding a payment for, the doula and lactation services. Those are added on top of this total.
That is correct, yes.
Okay. And then I was curious how you are splitting out the prenatal and postpartum care from the delivery when people are using the global bundled codes. Are you using a consistent formula to allocate what percentage you estimate was for prenatal versus the delivery, or what's the methodology?
Yeah, that's what we're working through right now. So we're looking at for those deliveries that are not using the global code, what are the proportions there, and trying to make sure that they at least roughly correspond to what the global code would include in terms of visit count and so forth. So that is a process that we're working through. If you have any suggestions, we would happily take them at this point. But otherwise, we're going to see what the data says.
Okay, I have seen other states, or actually in particular payers that have a certain percentage breakdown that they consistently apply. And so if I can dig out that information, I can send it to you.
Great, thank you. All right. And next we'll be looking at social risk adjustment. Our year one proposal is that the area deprivation index, ADI, would be used for social risk adjustment. The ADI is a measure for ranking relative income, education, employment, and housing quality between neighborhoods. A low ADI score indicates affluence, and a high ADI score indicates high levels of deprivation. The specifics of how ADI will be used are still being determined, but factors such as hospital cost differences will be removed to not influence the risk adjustment. ADI will be applied in a budget neutral manner. So risk adjustment will pay providers with higher risk patients more compared to providers who have lower risk patients. For future years, other adjustments, including individual level, may be used as further data becomes available. And we have a discussion question here, kind of in two parts, but the first is asking what data could be gathered for future risk adjustment. And some of the feedback that we've already received is that some diagnosis codes like Z codes could be used. And if they are, though, we wanted to ask you all what the impact on administrative efforts to record that necessary payment information would be. Karen, you have your hand up.
Yeah, I feel like we have talked about this before, but whatever validated set of social risk questions is being asked, I think the more important question is what can be done with that data. So just ensuring that we're not collecting data that we have no use for or referral opportunities for. And also finding a way to ensure that we are encouraging that data collection be done in a respectful, culturally appropriate manner, and ideally not by clinicians. People, for very good reason, have a lot of fear about disclosing that data to clinicians, and may be much more likely to be honest with a lay health worker. I know that's not the question you're asking. I just think those are important considerations in that planning process.
Yes, definitely. And thank you for that comment.
I also
Mark?
have a comment as well, but go ahead. I can't see the hand raises, so.
Okay. Well, Paula, I think you had unmuted first, so go ahead.
You know, for a group like ours with the 200 plus providers that practice in very diverse communities, how is that going to kind of be reflected, or how are we going to be able to attribute the patients to those communities when the dollars flow up to one large tax ID that's spread across the state? I think from an administrative perspective, I think that's something that, you know, we're going to have a give and take about, because I just see it could potentially be on both sides difficult to administer.
Mm-hmm. So if I'm understanding you correctly, your concern is that the
one tax ID that we bill under that represents 200 plus physicians across Connecticut in various ADI locations, high and low. So how to administer this is going to, I think, be a little bit more difficult than it sounds when you're only practicing in one community.
Sure. So in that case, it would be blended. It would be the average risk over that whole population. So that would mean that you would see the one payment for whatever the average ends up being. Okay, so
you've contemplated this.
A little bit, yes, but so it would be the average over the tax ID level. Mark, you have your hand up.
I do. I don't know, Paula, how that affects the ability internally within a 200 physician organization or practitioner organization with respect to how rewards flow through to your network of 200, because this essentially blends out what might be a factor of that goes into individual performance. So it's just a sort of curiosity now that I understand how the state's proposing to create a blend that applies for a large practice or a medical group. The on this slide, it's a little ambiguous as to whether you're referring to the price benchmark or the payments, because the fourth bullet says risk adjustment will pay providers with higher risk patients more compared to providers who serve lower risk patients. So I had thought that there was an adjustment being contemplated as it pertains to the bundled fee, prospective payment, to compensate those who will require more resources to effectively engage patients, versus the use of ADI as a social risk adjuster alongside clinical risk adjustment for setting the price benchmark. So for clarity, are are you planning to make adjustments to both the prospective payment and the price benchmark, and the items on this slide, to which do they apply?
So right now, the risk adjustment would primarily apply to the overall target price, so the overall bundle price. And that's in part just due to data timing. We don't necessarily know the ADI of patients that are coming into your office until it's the data comes back to us at some point later, and we can determine their information based on that. I won't say that any adjustment for the prospective payment is ruled out, but that's that would already be looking at the historical information for that specific provider. So some of that might already be accounted for there, and we just wouldn't want to double count that by doing risk adjustment.
Yeah,
but yeah, I wouldn't say that it's ruled out.
That makes sense. I can understand that doing it to the price benchmark allows it to be factored into the overall gain share calculation. And assuming you have a generous enough gain share, it can compensate those providers who are serving higher social risk patients. So thank you for the clarification in terms of this slide. And with regard to Z codes, just to tag on, I'm hearing really mixed things about the future of Z codes, and I certainly don't believe that the use of Z codes is sufficiently widespread and standardized necessarily to be an early basis for use in social risk adjustment. But that's just my observation from what I've been following nationally.
Okay, thank you for that. I'm going to pause there another moment for any other comments. All right, then I'm going to turn it over to Bree to talk through the prospective payment trigger.
All right, thank you, Martin. Good morning, everyone. The prospective payments will be triggered on either a Z34, Z3A, or O09 diagnosis code indicating a pregnancy in the second trimester. About 3/4 of pregnancies already include a claim with a second trimester code, of a Z34, Z3A, or O09 code. So we're already getting a lot of the data in these. We would just need to make sure that everyone is coding under one of these 3 types of codes. And then submitting a claim with the second trimester of a Z34, Z3A, or O09 code will be required to begin that prospective payments. And then that claim and all subsequent maternity related claims for that member from the provider will be paid through the prospective payment. And then I'm going to keep going to the next slide, and then we can come back if there's questions on that. Because the prospective payment is going to start in the second trimester, all claims submitted in the first trimester will be paid fee for service. And about 80% of miscarriages occur during the first trimester. So this approach avoids beginning prospective payments when miscarriages are most likely. And then we would have to try and reconcile that or figure out how to stop those. However, though, this also means that add-on doula payments are not provided during the first trimester. So our discussion question from there is, any challenges from providers' perspective on implementing this triggering approach to prospective payments?
Hi, I have a question.
Mhm.
Can you tell me how you all arrived to determine that doula services wouldn't be provided until second trimester?
It's mostly just from a point of how we're able to pay for them. So so since we're including in the bundle, if that prospective payment isn't triggered, it won't change necessarily the amount of funds that are flowing to providers for doula services. There's just not a mechanism for us to pay for doulas in a outside of currently the prospective payment that we're planning directly to providers. And so that really limits us. And, I know this has come up several times, which I think is a fair point, that like doula services may be very valuable in the first trimester, which I think PSS is not in disagreement about. It's just, this is more of a practical issue about technically for us, when we trigger the payment, if we trigger it in the first trimester, there's going to be a lot of miscarriages that is really hard on the back end, technically difficult, challenging for us to then have to probably pull back dollars from providers because we haven't identified those prospective payments were triggered in the when the compared to when the actual miscarriage occurred. So it's more of a technical issue than anything else at this time. And I think there'll be a interest in the future re-looking at this and how this works and making sure doula services are provided as early as is feasible. Again, recognizing some of the technical limitations that we're up against.
Larry, I see your hand up.
Yeah. So, Brad, I think you may have answered my question, but I'm going to pose it anyway. So I understand the trigger being the second trimester. Actually, voluntary terminations is about 6,000 out of 22,000 pregnancies in the Medicaid program. So that's a huge consideration also. So I understand that decision. Was there any, and it may not be technically feasible, to look for a claim from the same provider during the first trimester and make a retrospective payment of the same magnitude to cover the first trimester care?
Great question, Larry. I think there may be some, so in terms of the amount, I think there's some challenges we'd have to go back to discuss the feasibility of doing that. I think the challenge often is going to be, though, that in this case is that those that have a miscarriage or you have a pregnancy terminated, there's no mechanism to go back and pay for those. So we don't know who's going to have a miscarriage in that first trimester. And so even by retrospectively paying for those who still have someone that has a pregnancy in the second trimester, it's not going to cover those costs, if that makes sense, which I am not sure if that,
I'm saying like not pay fee for service for those 90 days, but then go back and see if you get the second trimester trigger to cover all of the care in the first trimester with the same payment that you would for the other two trimesters and just rebalance the dollars. Just food for thought.
Thanks, Lee.
All right, Mark, your hand is up.
Sure, I have along the lines of what Larry's trying to solve for. It does seem to me, well, I can't help but be concerned about the critical importance of early engagement in obstetrical care, which I know is shared amongst advisory group members, and the potential value of doulas in supporting that early first trimester engagement. So one option would be that for women that qualify for the second trimester, that is, they have a claim that qualifies in the second trimester and there was not a miscarriage in the first trimester, and there was a fee-for-service payment that occurred with that same provider in the first trimester, that could qualify one to back bill for the doula costs incurred in the first trimester. At that point, you're not making the payment for those who've miscarried, and you are rewarding a provider who deployed doulas early as a means to effectively engage people in their community who in order to access the prenatal care timely. I know it's tough to have wheels within wheels of complexity when you're doing a first off implementation. So appreciate if it's not possible, but that's just one suggestion.
So I think we're not necessarily precluding doulas from having the care provided, and the amount that we have allocated is the same whether we be spreading it into the first trimester versus the second and third. And so it's more of a mechanism. So, providers that are working with doulas, there's no reason that doulas couldn't be involved, and the amount wouldn't necessarily change that we're paying for those services, if that makes sense. It's more of the challenge, I think, at least if I'm putting my provider hat, is like there might be a number of individuals we're serving that have a miscarriage that maybe we try to get them involved in doula services, but then there's no mechanism to pay for it, to pay for those services. And that, I think, is probably the biggest challenge, if that makes sense. I think that piece of it is operationally quite difficult, and I'd welcome maternal health providers weighing in, because I think they have more of an operational this is somewhat more of an operational challenge than I think we probably all agree, yes, we should have doulas engaged as early as possible. Early prenatal care, super important. It's one of the quality measures that's going to be pay for performance related to payment. So that's going to be super key. This is a little bit more of a somewhat technical and operational challenge that we're trying to solve for, and we welcome thoughts about how to do that effectively. And assume we're going to have to come back to this even post-launch to look at it and rethink and continue to think about it. But appreciate anyone's suggestions and thoughts here.
And Amy, I see your hand is up.
Good morning. At our community health center practice, we refer to doulas as soon as the woman comes in pregnant for an intake. So we do have a lot of first trimester interactions with our doulas. And if there is a miscarriage, they support the mother's emotional and physical needs during that process. So it is an important service. I understand that we're seeing the bundle as it relates to, it sounds like, birth outcomes. And I think moving forward, it will be important to look at sort of women's wellness as part of that continuum of reproductive health and deliveries.
Thanks, Amy.
I think I saw everyone's hands up, at least right now, but are there any other questions or thoughts on this topic? Great. Martin, do you want to go to the next slide, which I believe is just any other general questions or feedback from maybe something previous in the PowerPoint or that you just saw or that you just thought of? All right, looks like nothing. Brad, do you want to say anything to close it out?
Just to say, I think, again, we appreciate the comments and concerns and also suggestions that are coming in. And as we are getting closer to having details finalized, we'll obviously want to have something that we can present out and that can be clear to not only folks that are participating, but also those who are not engaged. So we can socialize it, make sure people understand what it means to be participating in the bundle. But again, we're going to need to continue to evaluate how we're doing this and what's working and what's not working well. That's going to be very clear, including a lot of the things that came up today, operationalizing doula, both payments, engagement. Those are going to be really, really important topics that we need to come back to as we try to, one, roll out this program and then monitor utilization of doula services, which I think we all know are really, really important to the success of the program and also improving health equity for the members that will be served underneath this bundle. So just again, thank you guys for your engagement. Thank you for your thoughtful questions and considerations. We'll look forward to talking to you guys in the next year. And I don't know if anyone else wants to say anything before we close, but. All right, well, thanks again. Have a happy holidays, and hopefully everyone's able to take a little bit of time off, and we'll look forward to re-engaging in 2023.
Thanks, and great. Just congratulations to you and the team for such thoughtful work in putting this together. Really appreciate the consideration of all the feedback you're giving.
And thank you to you all for the engagement here. I know this is a big time commitment, and I just want to say on behalf of Medicaid, I really appreciate that input, and we're taking your comments very seriously.
Have a great holiday.
Thank you.
Everyone.
Happy holidays.